Hello, my name is Melanie, and I want to welcome you and thank you for factoring with me. First, let's take care of some preliminary issues. Next, let's talk about pressure injuries. Until 2016, they were termed pressure sores. They can occur over a bony prominence as a result of injury to the layers of skin. The most common areas include the sacral or coccyx area, the heels, knees, ankles, occiput or back of the head, ears, toes, and shoulder blades. They can occur due to pressure or as a result of friction or shear injuries. Some common risk factors include immobility, incontinence, poor nutrition, dehydration, blood flow problems, or the inability to sense pain. They can occur within hours to days and affect millions, costing billions to treat and may result in death. Some background information for you is that Barbara Braden and Nancy Bergstrom developed this Braden scale in 1984. It has become the most widely used risk assessment tool for the identification of pressure injury risks. It includes 6 subcategories, which when totaled together are scored between 6 and 23, with the lower scores meaning higher risk for development of pressure injuries. The tool, when used in combination with critical thinking skills, can be allowed to score and intervene in order to improve patient outcomes. Each subcategory is scored between 1 and 4, except friction and shear, which is scored between 1 and 3. The scale should be accessible at your facility for use in varying patient populations. The 6 subcategories include sensory perception, moisture, activity, mobility, nutrition, and friction and shear. These include extrinsic and intrinsic factors that place the skin at risk for breakdown. Scoring each category and adding the sums together produces a total score that defines the patient's risk level. The link above will allow you to view the scenarios the staff scored in my pretest to gauge their understanding of how differing diagnoses affects perfusion, nutrition, mobility, activity, and sensation. Participation proved to be low on the pretest as staff complained of the length of the scenarios. Regardless, there was enough participation to gain insight into the staff's need for education. Sensory perception is the decreased sensation for discomfort or pain, or the inability to sense the need to change position or shift weight. The patient may complain of numbness and tingling in the extremities, or a feeling that their limbs have fallen asleep. Ensure to assess light touch in each patient. Diagnoses that affect sensory perception include diabetes mellitus with peripheral neuropathy, a CVA with residual hemiparesis or hemiplegia, Raynaud's syndrome, multiple sclerosis, systemic lupus erythematosus, spinal stenosis, spinal cord injuries, uremic patients in end-stage renal disease, rheumatoid arthritis, scleroderma, fibromyalgia, and patients with vitamin D deficiencies. Comprehensive assessment includes the patient's medication regimen. Some medications that affect sensory perception include chemotherapeutic agents, radiation, topiramate, digoxin, metronidazole, sertraline, amiodarone, HIV, and TB medications. Some interventions include turning and repositioning routinely or every 2 hours, protecting bony areas with padding or foam, removing or padding pressure-inducing devices from vulnerable skin areas, and avoid heat or cold packs. Moisture. This is how How often is the skin exposed to moisture? It can occur with prolonged exposure to moisture on the skin. The natural pH and lipid barriers of the skin are changed by urine or feces, causing maceration. The skin is more prone to shear, friction, or breakdown with moisture. The patient may require more frequent linen changes. Diagnoses or conditions that create risk for moisture damage include incontinence, ostomies that leak urine, stool, or respiratory secretions, obesity due to skin's contact, contractures, congestive heart failure with third spacing that causes weeping onto the skin, wounds with drainage, dementia with incontinence as a comorbidity, and persistent fevers. As part of my pretest, I threw in a question about fevers to gauge the staff's perspective. More than half of the staff recognized that having a fever can predispose the skin to moisture. Interventions aimed at reducing moisture on the skin include the use of a Purewick for women, condom catheters for men, moisture barrier creams, toileting schedules, skin prep prior to the application of ostomy pouches, alginate to control drainage of wounds, and weeping skin. Remember to use only one moisture pad under the patient, and no briefs are best practices. Consult occupational therapy for orthotics for contractures, the wound ostomy and continence nurse, and the physician. Activity refers to how the patient moves physically from one place to another. The patient can be considered bedfast, meaning that they are confined to bed for a particular amount of time. This may change throughout a shift dependent on the length of greater than 4 hours after a procedure. The patient can be chairfast, meaning that they cannot bear their own weight or have to be assisted into and out of a chair. Persons that walk occasionally walk only for short distances, but spend most of their time in the bed or chair. Persons that walk frequently means that they walk outside of their room at least every 2 hours while they're awake. Diagnoses or conditions that affect activity levels include spinal cord injuries, CVA with hemiparesis or hemiplegia, chronic obstructive pulmonary disease, hip fractures, limbs intraction, mechanical ventilation, obesity, or patients that are fall risk on bed alarms, persons with current pressure injuries requiring no weight bearing of a limb, and those with motivational issues precluding out-of-bed activities. Interventions include padding bony prominences, ambulating patients early, turning and repositioning routinely, having the patient out of bed at intervals of 1 to 2 hours, shifting weight while in a bed or chair, encouraging ambulation, and consulting physical therapy and occupational therapy. Mobility equals how the patient moves their body across surfaces, how they change positions. Some patients make no slight changes in position without assistance. Others have occasional, infrequent slight changes without assistance, but major changes require assistance. Some make frequent slight changes in position, while others make frequent major changes in position independently. Low scores equal risk for friction and shear injuries. Diagnoses or conditions that impact mobility include Parkinson's disease, muscular dystrophy, cerebral palsy, Hailey-Vorton-Spott's disease, chronic obstructive pulmonary disease, heart failure, arthritis, and acute or chronic pain. Interventions include the use of pressure-reducing mattresses, turning and repositioning routinely, the use of wedges to help maintain positions, and consulting physical and occupational therapy. The subcategory of nutrition includes weight loss, weight gain, the ability to feed oneself, swallowing difficulties, and those on tube feedings. As part of a comprehensive assessment, we should be assessing labs, including the albumin level, prealbumin, and transferrin levels. We should also be assessing the amount of weight loss or gain that's occurred over a period of 6 months and the usual pattern of meal intake. Some interventions to improve a person's nutritional status includes providing snacks and fluids with a turning and repositioning schedule if not contraindicated, routine weights, accurate intake and output records, the use of vitamin supplements such as vitamin A, vitamin C, vitamin E, and vitamin zinc, increase protein intake if not contraindicated, assist with meals if necessary, promote good oral hygiene as it enhances the appetite, and ensure dentures are in for those that wear them and that they fit well. Consult speech therapy, the dietitian, and/or a nutritionist to help with nutritional status. Those patients who are on tube feeding or TPN constitute adequate nutrition. The final category is friction and shear. Friction can occur when changing positions with increased risk when the skin is moist. It may also occur from restraint use when the skin rubs against the restraint. There's an increased risk when the restraint is placed over an IV site or other medical device, causing pressure. Shear injuries may occur when a patient slides down in bed and the bone shifts, but the skin stays in place, causing an opposite direction pull on the skin. Some interventions that reduce friction and shear are maintaining the head of the bed 30 degrees unless contraindicated, padding vulnerable skin areas, use of a lift sheet, trapeze bar, or other lifting devices, elevating the knees to prevent sliding down in the bed, and adequate hydration of the skin. Other considerations for lower Braden scale overall scores are advanced age. There's no clear definition of advanced age, which makes it difficult to categorize this risk factor. As you can see, there is no real consensus among the staff when it comes to advanced age as well. Other considerations include alterations in tissue perfusion. Things that cause alteration in tissue perfusion include current or past tobacco use, fluid volume deficits, low diastolic blood pressure, sepsis, vasopressor use, diabetes, cancer, anasarca, anemia, chronic or end-stage renal disease, peripheral vascular disease, cardiomyopathy, coronary artery disease, and heart failure. The post-test proved to be more enjoyable for the staff, with more participation, as more multiple choice questions were employed with the inclusion of one paragraph length patient scenario. For future education, I will use this information to cater my pre-test for maximum participation. In summation, the Braden scale should be used as a risk assessment tool in combination with clinical reasoning skills to reduce risk to patients for developing pressure injuries. It has been shown that consistent scoring requires training, which includes scenario-based education. It is not about right or wrong, but consistent scoring and intervening to prevent occurrences of pressure injuries that prove costly to patients and our healthcare system. Prevention requires an interdisciplinary team approach as suggested with consults for speech therapy, physical therapy, occupational therapy, the physician, the dietitian, and the healthcare technician. Thank you for joining me as I factored the Braden scale. I will now open it up for any questions.
covered all over with beautiful skin. Skin covered all over from ankle to chin. Lovely skin on faces and noses and everywhere. Skin on tummies and toes and under your hair. It's even there. Oh, skin. Wonderful colors and beautiful tones. Think of without it, you're nothing but bones. Skin is ever so lovely, no matter the color you're in. Let's hear it for skin. Beautiful skin. Without skin for touching and rubbing, how much we'd miss. There'd be no hands for shaking and scrubbing, and just think of this, no cheeks to kiss. Oh, skin, wonderful colors and beautiful tones. Skin, keeping the water off muscles and bones. Skin is ever so lovely, no matter the color you're in. Let's hear it for skin.